First of all, I'm very grateful to James and the university for hosting what will be a number of events this week to try and increase the awareness of eating disorders in our society and in our community. And when I was asked to come along and talk, in previous years I've just talked about eating disorders, but this year I wanted to talk a little bit more about how we've been working over the last mainly 10, 15 years to try and transform eating disorder service provision in Dorset from what it had been to what we're making it in line with the evidence and making it easily accessible. So, there we go. So, as I said, thank you for the opportunity. I'm going to talk a little bit about eating disorders, the numbers in Dorset, what are they, brief discussion of causes. I'm not going into that in too much detail. How can we transform services, and what we have done in Dorset. So just some figures to sense that. One of the things just to know that once I start to talk, I'm difficult to stop when it comes to the topic of eating disorders. But if you have a question, just put your hand up and I will stop and try and answer it. Anorexia nervosa affects about 1 in 150 15-year-old females and about 6 times less males. So it's also 19 in 100,000 females will have anorexia, about 2 in 100,000 males. They're the most recent figures I could find, and they sort of reflect what we've always known, is that anorexia nervosa has always been much more, as with other eating disorders, associated with females more than males. Although some information is emerging now that would suggest that figure is wrong. I've just noticed it's not 1,000. That maybe newer forms of eating disorders are beginning to emerge more frequently in males. Every year there are as many as 18 new cases of bulimia nervosa per 100,000 of population. So again, it's more, the incidence of bulimia is higher than anorexia nervosa, so more, and the prevalence. So the cases of bulimia nervosa are very rarely seen in people under the age of 13. Very, very rarely seen. Whereas anorexia nervosa tends to start much younger, 11, 12. And approximately 4% of women suffer with bulimia during their lifetime, but it is again less common in men. So the population, just to convert that into Dorset, there's that number of people in Dorset. So we would be expecting about 88 new cases of anorexia nervosa a year and 144 new cases of bulimia nervosa in that population in a year. So this is the incidence of a disease in the population, so the new cases occurring each year. But actually, there's already an amount of the disease already in the population from previous years. So the prevalence is the number of people with that disorder that might be in your population at any one time. And for anorexia nervosa in Dorset, we would expect about 369 people, and for bulimia nervosa, 1,230. Yeah. So that's the difference between incidence and prevalence. Just some other figures. Anorexia is the 3rd most common chronic illness in teenage girls. And the incidence of bulimia nervosa trebled between 1988 and 1993. Since then, we're wondering if, because bulimia nervosa was only first described in 1979, first named as a diagnosis in 1979, whereas anorexia nervosa was first described in 1874, at exactly the same time in Paris and London by 2 completely different people in exactly the same year, which was rather bizarre at that time. But we think that this increase in incidence in bulimia nervosa actually came about because people noticed it more. People picked up on it and identified it more quickly, and that's why it trebled. Because it certainly hasn't continued to go like that. It has reached a plateau and it's been pretty stable since then. And eating disorders, particularly anorexia nervosa, increase the mortality risk Recent findings indicate individuals with anorexia nervosa have mortality rates 5 times higher than that of age-matched peers. And I suppose sometimes I've worked in eating disorders for about 23 years, and when I first started it, people used to call it a slimming disease, and people didn't take it terribly seriously. But actually anorexia nervosa is perhaps one of the most, it is a very serious illness if left completely untreated. So the types of eating disorders that people tend to know, anorexia nervosa, bulimia nervosa is perhaps another one. Binge eating disorder, perhaps less well known, but it's a type of eating disorder where the person overeats in a way that's as compulsive, is out of control, and there is no purging, which is what happens in bulimia nervosa. But perhaps interestingly, if you took all of these 3 diagnoses, in terms of the number of eating disorders that we actually see in services, they only come to about 40% of the people who turn up, because most people turn up with an eating disorder not otherwise specified. And this is a diagnostic category which basically captures, say, someone with anorexia nervosa who has, you have to have 5 criteria for a diagnosis. If you've only got 4, you don't attract the diagnosis of anorexia, you attract the diagnosis of eating disorder not otherwise specified. And it's a diagnostic issue. And the recent changes in diagnosis are going to lead to anorexia being expanded, bulimia being expanded, binge eating disorder being expanded, and this one being reduced quite significantly, so that we'll have a better set of diagnoses to capture what we're actually working with, because the vast majority, I think it's over 60% of people who presented eating disorder services would not present with any of these 3 diagnoses. These are not eating disorders. And I put them up because there's quite a lot of interest in these types of disorders at the moment. The first one is really where someone has a particular, they've got concern about a particular area of their body that they see as defective. And their focus is very much on that area, nothing else. And they don't have other eating disorder behaviors. Whereas muscle dysmorphia is, people have called it orthorexia. This is where people spend endless time trying to build themselves up in size, to try and build musculature, because they're convinced that they're very small. So even when they're hugely muscular and stuff like that, they still don't see it, and that's why it becomes a disorder. There are similarities to what happens because it's linked to appearance, but it's not an eating disorder. So when it comes to people with eating disorders, they're often very reluctant to seek help, and I'll come back to that as we go on. Also, people with eating disorders tend to be very ashamed of their illness. For all sorts of reasons. One, some of the things that the behaviours that they do, the impact of their illness on people around them. They can often be terribly ashamed about that. And they're also, people with eating disorders can often be very ambivalent about change, and this is something that perhaps is difficult for people without eating disorders to really understand. That someone with an illness might actually not be as committed to recovering from it as everyone would expect. And I'll explain a little bit more about that later. But interestingly, eating disorder patients tend to go to their GP much more than the rest of us before they're diagnosed, but it's often for other issues. So it's often for issues such as they feel anxious, they feel low mood, they may have issues to do with their gynecological presentation or indeed gastroenterological. So they might have pains in their stomach, they might have other bowel problems. So they often present, and the person who did it just looked back at the medical records of people diagnosed with anorexia and found all of this. So there's opportunities for the disorder to be picked up earlier. And that, as I will explain, that's really an important change. So some other things about eating disorders. Eating disorders are a mental health problem with physical signs. So they straddle how we traditionally have split up services. We've got mental health services, and we've got physical health services. So your Royal Bournemouth Hospital and your St Anne's for Dorset, or Pool Hospital. And what happens is that sometimes eating disorders get stuck in the middle of that, because they need help from both often. They need physical health care and mental health care. So that can create its own problem. They are serious mental illnesses, and I have worked all of my career to try and make sure that people get that and don't dismiss it as a fad or a diet gone wrong or anything like that. These are serious illnesses that need to be treated seriously. It's not just about food. It really isn't just about food. And sometimes the worst thing that people can say to someone with an eating disorder is just eat. As if that was the simplest thing in the world. And perhaps to us who don't have an eating disorder, eating is a simple fact of taking in energy or calories. But for people with eating disorders, it has a whole different set of meanings. It can often be about coping with emotional distress, and it becomes that in the sense that an example would be in if you are in a position where you're emotionally distressed by your surroundings and you have an eating disorder and you start to diet and you focus on diet and exercise and avoiding food and what you weigh, and very quickly you don't think about the other circumstances you're in. So that distress is no longer as prominent in your mind as are your eating disorder thoughts. So it comes to replace it as an alternative. And sometimes people have talked to us about a sense of control in eating disorders. And both carers and the people who suffer from eating disorders talk about how they feel controlled by this illness. How this illness tends to take control of a person's life and put in place lots of rules and regulations and ways of living that they have to follow. And also patients have talked about sometimes feeling in their lives so out of control in every other area of their life that the only area of their life they can control is what they put in their mouth. So that's where eating disorders can add just some more layers of complexity. And a particular impact of an eating disorder can be, it can seem to become their identity. It can seem to become who they actually are. I am anorexic, rather than still being the person. So it almost overlays their identity. And this can create mixed feelings about being helped and about being in recovery. So the individual might actually not want to get into recovery, might not want to get into treatment, might actually resist the idea that there's anything wrong, and actually feel, hold on, no, this is a good thing. Everyone else is the problem, not me. So causation. This is another area. I used to talk about predisposing, precipitating, and perpetuating, until one of my brothers pointed out that was ridiculous. Because essentially what we do think is that there are some things that make people more vulnerable to have an eating disorder. There are then events that happen in a person's life that might contribute to their vulnerability, that makes it happen. And then we think there are circumstances in a person's life that will then maintain the disorder. Yeah? So the disorder gets a hold and then is maintained. And that's what we think actually causes it. But we don't know what causes it. And often when we're working with individuals and their families, they want to know what causes it. And unfortunately, over the years, that's caused terrible problems, because people have gone and blamed families. They've blamed all sorts of things, which has been terrible. It's had a terrible impact. Because if you imagine for families who have someone who's unwell to then be told it's your fault, that's just horrendous for the family. So looking for an individual cause has often caused more problems than it solved. When it comes to genetics, we know that if you're an identical twin, which means you have the same genetic makeup, you're only 50% likely to have anorexia if the other twin has it. You would expect if it was completely genetic that if one had it, it would be 100%, but it isn't. So there's a huge contribution from others. Non-identical twins don't have any greater chance of having an eating disorder than a sibling. So it's about 10%. So genetics plays a role, but it isn't the be-all and end-all. Gender, I've said to you, being born a female puts you at greater risk of having an eating disorder. We believe that individual characteristics, the research shows that certain types of personality, certain characteristics occur more frequently in those with eating disorders. So people who tend to be very conscientious, very perfectionistic, maybe quite sensitive, high achieving, all of these occur more frequently in the eating disorder population than you would expect compared to the rest of the population. Environmental and social factors and environmental and social factors are linked to. We know that where if you have two environments, so a high-performing music school and a high-performing dance school, there will be more people with eating disorders in the high-performing dance school than there will be in the high-performing music school. Even though the personality types will be quite similar, we will have more, and we think it's because of the extra emphasis on appearance. Cultural and ethnic, for years, people said it was a Western disease. Eating disorders were Western diseases. They're not. They actually occur across the world, but they do seem to occur more frequently in societies impacted by Western ideals, and I'll come back to that very shortly. Keep pressing the wrong button. So some other factors that we find occur quite frequently in people with eating disorders is a low sense of self-esteem, a sense that they don't value themselves in quite the same way as perhaps other people do. Weight and shape. We know that sometimes there's a higher percentage of people who've been overweight who then go on to develop eating disorders later. In terms of difficulty with relationships, so social anxiety occurs more frequently. Perfectionism I've talked about, and there is a growing body of research that now identifies there's a type of perfectionism which just paralyzes people. They're unable, very, very capable people who are unable to submit any work at all because it's never good enough. It's never perfect. So it paralyzes the individual and makes them unable to deal with problems. Childhood eating difficulties are often more represented later in life with people who have eating disorders. Sexual abuse and emotional abuse, they're no more frequent in eating disorders than they are in mental health. Yeah? So it's the same sort of level of percentage of people who report it. And one of the issues that does come up is transitions from childhood to adult. Transitions just generally, so puberty, leaving home, a role change such as divorce. We've got a small bulge of eating disorder cases later on in life. The majority of people present for treatment somewhere between 11 and 25. And then there's a sort of a drop off, and then it comes back up again in the mid-40s. Just a small increase. And bullying. And puberty is of particular interest because one of the earliest researchers into eating disorders in this country was Professor Arthur Crisp. And he noticed that when he admitted people to his inpatient unit, he could get them to eat up to about just below 7 stone, just before they would be starting to menstruate again, and then they would drop off again. And his view was that actually anorexia was a way of avoiding maturing, avoiding becoming an adult, avoiding becoming an adult woman, and what that meant. It isn't quite like that. I suppose that there are some things that change from child female to adult female is significantly more than it is from child male to child adult male. And actually they have found that if in puberty starts and you lose about 5% of your body weight, puberty stops again. And if you weren't prepared for puberty or you came into puberty quite young, it can be, and I'm being very careful in choosing my words here, but some people say that transition can be really challenging emotionally because it goes from a world of quietude to an emotionally roller coaster life. And if you can switch that back off again by going on a diet, you didn't intend to, but it might be quite reinforcing not to go back up. And that was what he observed, that he had this sort of plateau of people who would get to just below what they would normally menstruate at, and they wouldn't go above that. So what part of the body needs the most energy? The brain, absolutely. How much do you think it needs? Say on average we need 1,800 to 2,200 calories a day. How much does the brain need?
20%.
20%. Close. Needs about 500 calories. 20 of 2,000 calories needs nearly a quarter of what you need just to keep it going. The other question I sometimes ask people is, if I lay in bed all day, did nothing else, just lay in bed watching telly, how many calories do you think I'd need to consume to keep my weight stable? I'm just lying in bed, that's all I'm doing. Somewhere between 1,000 and 1,500. And when I talk to people about that, they look at me as if I'm going, you're lying down, you're doing nothing. You're just lying there. But I'm not. I'm breathing and thinking, and my heart's beating 60 beats a minute, and my kidneys are working, and my liver's going at it, and everything's working away. So I need that amount of intake. But actually our society would have you suggest that you don't need any of that. That if you're not doing stuff. So that's what the brain uses the energies for. Some of the other considerations we have to take into in our society are our media. The way I look at it often, that if you look at the images of particularly women, but increasingly men portrayed in the media, you wouldn't think there was really the variety of us around that there is. You know, they look very similar, of a certain type. I think also there's a gender stereotyping, the role of women and how women have had their roles determined over the years. Researchers, certainly feminist researchers, would argue that it isn't a surprise that it's women who get more of these disorders than men. And it's linked to issues of power and control from their understanding of it. Advertising I've touched on. I've got a slide, I think I have it next. This is just wonderful, isn't it? You know, these are, if you can see this is Luke Skywalker and Han Solo from Star Wars. And this is how they looked in 1978, like the rest of us. But by the time they got to 1998, they'd been in the gym for the previous 20 years, and they'd turned into something completely different. So if people tell me that media doesn't influence the perception of shape, I just need to show them that. And you just have to look at the Barbie doll that wouldn't actually be possible to exist if you mocked her up to normal size. But this is, when people argue that society has no role in changing the perception of how we want to see things, the child who gets this one 20 odd years ago gets a different image of what it is to be a hero in Star Wars to this one. Yeah? So it's just interesting. Dieting. I hate dieting, not because I don't like to do it, because it doesn't work. And if you want to, you can look up all the research you care to look up anywhere in the world shows dieting doesn't work. And if it did, we wouldn't need a new one every week, and there wouldn't be a new one on the front page of every magazine. And what we tend to find is that people who diet tend to regain the weight plus 10 to 15%. because their body thinks they've been in a famine and it's preparing itself for the next one. So the body actually preferentially takes on more weight. And there was a great study done by Ansel Keys in America, which you wouldn't get ethical approval for anymore, where he took 36 psychologically sound, conscientious objectors to the Korean War and gave them a choice about participating in research or going to whatever their prison was for soldiers. And they took part in research. And basically they counted what they ate for 3 months, and then for 6 months they fed them 70 to 80% of the amount to see what happened. Now they weren't intending to psychologically torture these men, but what they wanted to see was what happens if you starve a human being, because of what had happened during the Second World War, and people died when you started to feed starved people. But what they found was, amongst all the other things that happened physiologically, was that these men began to lie. They began to pretend that they were storing food back in their room. They were cutting up their food into tiny little pieces and taking it back and hiding it in their room. They lost all interest in their social relationships. No interest at all. Some of them became depressed, anxious. One person became so manic he had to be taken off the program. So then they did that for 6 months, saw what happened, and then fed them back up again. And the idea was that they were to have 3 months of refeeding, and that would be fine. It took almost 2 years to get some of these men back into normal eating again. It took almost 2 years. And I suppose, just on a slightly lighter note, 9 of the people gave up their previous careers and went into food-related careers because they became obsessed with food. Food was so important. And I put down the industries because the dieting industry is worth about $4.5 billion in the United Kingdom. So it's quite a big pressure to tell you that how you look isn't right, and if you follow their particular whatever diet, you'll do better, as long as you pay them money. So these are some of the thoughts that I have, because I think in our society the cultural pressures that glorify thinness and place a value on obtaining the perfect body. The narrow definitions of beauty that include only women and men of specific body weights and shapes. And that's why being here under James's diversity banner is really important to me, because we are diverse and we need that level of diversity to be happier. Because if there's only a limited group of people who are acceptable, then a lot of people are going to be dissatisfied. Cultural norms that value people on the basis of their physical appearance and not their inner qualities and strengths. All of that adds to the idea that somehow you can achieve what you need to achieve by turning your body into a particular thing, to look a particular way. So moving on to transformations. Working with people with eating disorders, because they're reluctant to come for help, because the disorder straddles physical and mental health care, because it straddles transitions, you've got to think slightly differently about the types of services you provide. So one of the first things I would say is that I've worked very closely with our local clinical commissioning group to help develop and support investment into eating disorders to improve services. What we know too is that early intervention is best. So the earlier you intervene, the better the outcome is likely to be for the individual. Yeah. We know that, and historically, people with eating disorders didn't get treatment early. Sometimes we're waiting up to 6 months. That's still happening in parts of the country now. You can be referred to services, and it's 6 months before you're seen. Again, if you're ashamed of your illness and you finally are brave enough to go and tell someone about it, or someone notices, if you're a reluctant patient, you have to jump through a series of hoops to get into treatment, you're going to fall at the first hurdle. So you need to make access to it as simple as possible and as easy as possible. And this one is regularly occurs in eating disorders. Someone will go to their doctor or professional, and the professional will look at them and go, but you're not thin enough to have an eating disorder. You're not thin enough. Nowhere in the world would someone come along and say, you know, yeah, you've just started your infection, but could you go away and let it boil up for another couple of weeks there, because we really need it to be really bad before we get stuck into it. And that's why it's so ludicrous. People think people with eating disorders are thin. I would suggest the vast majority of people with eating disorders are not thin. They become thin if they have anorexia nervosa in particular, but the vast majority don't. So what we have introduced in Dorset is self-referral or parental referral. So now someone can just pick up the phone and ring us and say, look, I think I have an eating disorder, okay, let's come along and we'll see you and we'll assess you. We will liaise with their GP, but we believe that that's a way to help get people in. We have no more than a 4-week wait, says he, hopefully. The vast majority of people who come to us, and I'm talking 95% of people, will be offered an appointment within 4 weeks. Sometimes shorter than that. Certainly if it's urgent or an emergency appointment. If it's an emergency appointment requested, it will happen within 24 hours. And if it's urgent, within 5 working days. But routine, it's within 4 weeks. And also we now offer access to the service 7 days a week. Now it's not the full service on a Saturday and a Sunday. It isn't the full service on a Saturday because there isn't enough money invested in it to make everyone work on a Saturday and a Sunday. You can't do that. But there are people present on a Saturday and a Sunday who would be able to respond. So the population, going back to, has this made any difference for us? Well, in 2010-11, the service had 303 referrals, of which 21 were under 16. In last year, we had 463 referrals, 93 were under the age of 16. We think we're capturing people sooner. That's what we believe. We also think we're capturing more people. And the figures would tend to suggest that. But this figure to me is the most important one. It's almost 4 times more people are being captured. Being captured? Where did that come from? Being picked up younger. Yeah? So the right treatment. Increasingly, the NICE guidance were produced in 2004, which guided the treatment of people with eating disorders. Really the key recommendations were 1, family therapy for people under the age of 18. CBT was the gold standard treatment for people over the age of 18 with bulimia nervosa. Interpersonal therapy also worked, but we weren't sure why they didn't work in the same way. And those were the main well-supported findings for treatment. Since then, the research has moved on and we're going to get a new set of NICE guidance. They're coming out next month. And essentially, there hasn't been a huge amount of change in what they recommend for treatment. They do make different recommendations around family work. So now we have cognitive behaviour therapy enhanced, specifically for eating disorders. And that just looks at weight, shape, eating disorder behaviours, and stopping the restrictions that people have, and it's really just focused on eating disorders. And the enhanced part of it talks about perfectionism, body image, losses in your life, interpersonal strains. So that's the enhanced bit, because the CBT was already developed back in 1988, I think it was. It's by Professor Christopher Fairbairn, and he's now produced a more up-to-date manual where he's added in more. The multi-family work is a new addition, and that came from the Maudsley Hospital. And what the researchers there noticed was that you could actually do work with groups of families who all had someone with an eating disorder in it. And they have a program which runs over 4 days, where you get 4, 5, 6 families who've got someone with an eating disorder. You put them all in the same space, not necessarily a clinical space, and you go through certain interventions with them, together, separate, families together, adults together, children together, mix them up. And the outcomes for people who complete multifamily work is really fantastic. The research is now, they're up to about 8 years of follow-up, and they're talking in the regions of 85% recovery rates, which is phenomenal in psychiatry. Absolutely phenomenal. Even with CBTE for bulimia, the best outcome results in the research centres still only achieving about 62%. Yeah. Still, well over a third not responding to the best treatment we have. So having this treatment, so in Dorset, we've now trained everybody in this work. And I mean everyone. The admin people, everybody has gone off and done some training. So everyone is trying to sing from the same hymn sheet when it comes to multifamily work. There's a consensus that people understand what we're trying to achieve with young people with eating disorders. All the adult therapists have all been trained in CBTE. So we have the right treatment available. We also think that trying to, in contrast to how people used to blame families, we think families are the solution a lot of the time. Yeah? We think they're the main people who are going to help the person recover. Because as much as we're around 7 days a week, we don't live with the person 24 hours a day. They live with their family. Yeah? And it's supporting that family in dealing with something that is counterintuitive, really. This person won't eat. Why will they not eat? What's that about? Just eat. Filled with emotions. So actually helping people to learn skills, to work with their relatives in a more successful way, hopefully, is what we're doing. So we now run what's called carers training workshops. They're every 3 months. They take place on a Friday and a Saturday. And again, we've brought people down from the Maudsley to train the staff and the carers, because we've got a number of carers trained in delivering the carers training. So it isn't just professionals standing up there spouting off, it's people who've been in the same place as some of the people on the course, being able to say, this is what helped me. And I also think that to do transformations properly, you need to get to outcomes and evaluation. You need to begin to be able to demonstrate that what you're doing is making a difference. And in Dorset at the moment, we're piloting, we've been doing this for years using questionnaires, but I'm not sure it's as I'm not sure what word to use for it. It's not as comprehensive as it needs to be. So we're currently piloting a piece of software called Checkware, which actually allows us to do this live. To actually say to the patient at the end of each session, did this meet your objectives? Were we working on your plan? What progress did you make? Did I listen to you? Did I understand what was going on? Have we got an agreed plan? So again, we're trying to shift the idea that someone comes and gets done to. It's much more about you come, you work with us on the plan that you're going to take away and work on for the rest of your week. Does that make sense? So that's what we've been trying to do in Dorset. The other thing that we've worked very hard to try and root out is the idea of trying not to pass people off. Eating disorders occur around adolescence, but actually when I looked at the referrals to the adult eating disorder, 18 plus, and 83% of those referrals were under 25. So a lot of people are young when they come to us for services. So a lot of people will get to and for our young people's services, we have people who come to us at 16, 17, who in the normal run of things would have to leave at 18. They would have just gotten to know their treatment team and started to trust people and engaged in treatment. And then we would slowly wind them down and say, well, you have to leave now and go and join the adult world. And we think that's wrong. So what we've done locally is we have an all-age service, which is we have a transition team. So if you're 16, when you come to our service, you get treated by a particular group of people who work across my adult and young person's team. So your consultant stays the same, your systemic therapist stays the same, and your nurse stays the same. So you have 3 people who, if you turn 18, it doesn't matter. They'll still be the same. You're not going to be passed on to another team. The other thing we've done is we've got more CBT, not E, but CBT and trauma and anxiety work that we can offer people who come to us. So we can offer a little bit extra. We don't just focus on your eating and your weight. If you're anxious as well, we try and help you with that. If you've experienced trauma in your life, we've got someone who can help you with that. There are some areas that we don't have the expertise in, such as psychosis, or maybe autism and Asperger's, that we would have to try and get other people in. But what we're trying to do is just reduce the number of handoffs and moving ons that would happen. We're also in Dorset trying to work with our colleagues within the community. So GPs, acute hospitals, other specialist services where eating disorders tend to turn up. So particularly in the acute hospitals where people will suddenly turn up, and even with our service doing what we do, we still get people who just appear out of nowhere, who've been managed by someone for maybe a year, who are really, really, really unwell when they get to us. And they go straight into an acute hospital because they're that physically unwell. And what we've done is we've worked with our local hospitals to come up to work to what are called marzipan guidelines. I have a little smile on me because I think eating disorders and their guidelines, marzipan, yeah, great. They must have sat around for hours coming up with that acronym. But anyway, it means managing really sick individuals with anorexia nervosa or something like that. So that's what it's about. And these guidelines were written because people were going into hospital and well-meaning professionals were feeding them and making them unwell because they weren't monitoring certain things, so like phosphate. So we've agreed this, we've met with people in the acute hospitals and they all work to the marzipan guidance now. So they'll follow that. We've made contacts with local diabetes services, and actually my colleague Mickey is talking on Wednesday, specifically about the extra complications that arise when someone has an eating disorder and diabetes as part of their picture. Because there are extra risks in using insulin as a way of trying to minimize the use of calories. Yeah. It has greater physical health risks. Obesity services, we've been working with colleagues in obesity services to try and inform some of the work that they do. Trying to move away from the body shaming idea, move more towards health at every size idea. And actually on this Thursday, we have a specialist coming from London who has developed a whole model of working with people with weight and health at every size. And she's going to do a session. It's a small session just for about 25 people, commissioners, professionals from across the Dorset health community, looking at this as a model for possible adoption within Dorset to help us with the issue of obesity. Because some of what we're trying to do in managing the obesity epidemic is making it worse. So my children have been to schools and they're all weighed and measured and heighted and all sorts of stuff. And unfortunately, the people who were overweight were sent off to the fit club. So it took about 25 minutes for everyone who wasn't going to the fit club to change the name of the club. So the kids who were sent to the fit club were going to the fat club. So just unintended, people thought they were being helpful, more activity, but they hadn't thought about the consequences of how the rest of the community would react. And children can be vicious when it comes to these sorts of things. Yeah? So we do have to be careful about the messages we give out. And we've also begun to do quite a lot of prevention work. Well, not we particularly, but we work with I Feel, which is a local charity, and they've developed an intervention which is carried out in schools, and they go in and they talk about really more about a healthy body image, healthy diets. They don't talk about eating disorders because we know that if you just talk to people about eating disorders, it'll make the situation worse. Okay? The early work in prevention of eating disorders was all done about, oh, well, we'll go and scare the life out of people. We'll show them pictures of people, with really thin people, and it actually didn't. Actually, when they followed it up, they found that actually people were going, oh, that's what I need to be. So, those are the sorts of transformations, but this is just some common questions we tend to get. When people are using laxatives, we never tell people to stop them immediately. You must do it gradually. So if you're taking, in our case, we have people taking 80, 100, 200 laxatives a day. You have it, and you have it, and you have it, and you have it, so that by the end of 7 to 10 days you're finished. But do not stop immediately, because if you stop immediately, you will have a rebound effect, which will probably cause you more problems. Vomiting. If you vomit, don't brush your teeth afterwards. First of all, rinse out your mouth with a bit of sodium bicarbonate so that you don't rub acid into your teeth and erode the enamel. Because when you vomit, you bring acid from your stomach and it'll be still in your mouth. So create an alkaline environment in your mouth before you brush your teeth. If you find that you binge eat, and normally people binge eat when they haven't eaten properly, and they've done research on psychology students, probably a few of you around here, because you're the most researched group in the world, I reckon, psychology students. But anyway, they showed that if you allowed students to get up and have breakfast, says he with a smile, but anyway, have breakfast and then gave them lunch, and another group who didn't get up and have breakfast, and they both were allowed the same access at lunch, the group who did not have breakfast ate more. They just ate more, without even thinking about it. They just ate more. And what we know is that in the CBT theory of eating disorder, it talks about restriction being what leads to binge eating. Because you starve yourself and you starve yourself, and nobody, I always said this with such confidence, nobody craves lettuce. And then someone in the last time I was talking about this said, yes, I do. So I've stopped saying that now. But most people do not, when they're hungry, think of lettuce, or carrot, or apple. You probably think of high calorie, high sugar foods. So cake, crisps, bread, chips, all the stuff that's really, the body knows what it wants. It wants an instant hit. And what happens with binge eating is the person, if you're going to stop that, eat regularly, reduce dieting, and eat all types of food. The other thing is that people go off certain types of food, and then they're surprised when they start dreaming about them. Because the foods that you will crave will be the foods that you like. They won't be the foods you dislike. That's just... And the other thing is, when you're dieting, you're fighting that part of your brain. Not this part, this part. The oldest part, the bit that was in us when we were a lizard or whatever we were back in the day. That bit is only interested in keeping us alive. And it never sleeps, it never gets tired. So when you're bored, tired, angry, emotional, that's when it'll get you to eat, because this bit is more preoccupied, so you can't exercise your willpower over it anymore, and it'll slip in a quick binge eat, just when you're not expecting it. So it's not a simple thing. Weighing, don't do it. Don't do it, please. When you get on a set of weighing scales, what is the only circumstances that makes you feel good on a set of weighing scales? When it's gone down. So the only thing that's going to give you a good feeling will be when it goes down, which will reinforce whatever you were doing before then to make it go down further. If you get on and it stays the same, you're going to have to do a little bit more because it's not going down. And if it goes up, well, then you're going to have to do an awful lot more because it's not going down. So weighing doesn't help. And certainly, I think sometimes I should make weighing scales with big, wide windows on them and put personality types on them. Because sometimes people get on weighing scales and they get a sense of their own value by those numbers. So it says 8 stone, but they don't see 8 stone. They say failure, crap, useless. All those sorts of words, which then reinforces all of their eating disorder behaviours. So I would avoid weighing. I mean, of course, if you go along and your doctor wants to weigh you for health reasons, do. I'm not suggesting you turn down your doctor or anything like that. But I think there are very few occasions where you have to know what you weigh. Also, people often want to have a weight like this here. So I want to be 9 stone or 10 stone or 20 stone or whatever it happens to be. And we actually suggest you go for a range, anywhere within about 2.5 to 3 kilos round a point. Because if I drink a glass of water, full pint of water will probably weigh myself afterwards. I've probably gone up a couple of pounds because I've now got a pint of water sitting in my stomach. But I'm not really 2 pounds heavier. Am I? No. Because eventually I'll lose it. 80% of our body is water. So, roundabouts. So we do that. So really work on a range rather than trying to be so specific about weight. This I like because this, I think, is how you work with people with eating disorders. This is the fable where the wind and the sun had a bet about how they were going to get the man to take his coat off. And the wind just blew harder and harder and harder, and all the man did was pull his coat tighter and tighter and tighter. And the sun just gently sent down some heat, and he took it off voluntarily. And that's what I think is a key bit in working with people with eating disorders. Because the harder you blow against someone who's holding on to their eating disorder, the more likely they are to hang on to it. So you've got to work with them so that they take it off. So conclusion from me, eating disorders have profound effects on the brain and body and the social network for an individual. Genetic, environmental and developmental factors contribute to causes. Biological, psychological and social process maintainment, early intervention, before secondary effects become entrenched, it's essential to avoid harmful costs, and a collaborative approach to care is essential.